Hi, this is Dr. Coucher. I want to talk to y'all about creating concept maps. Quite a number of you have struggled somewhat on this assignment, and I know that others will struggle in the future, and I want to set y'all up for success. You won't be just ending with concept maps with us. You will take this on out through until graduation. So I hope this little brief presentation helps you. All right, so let's talk about our problem statement, our nursing diagnoses. I will not be working up a complete concept map. However, I'm going to take the bits and pieces, the ones that everybody seems to be having trouble with, help guide you to creating your patient-specific one. Look at your nursing process lecture. I believe it was from week 2 to help you to identify key components of what you will need. CM is our patient that I have created. I want you to look at all the key components of her information, and I want you to derive a nursing diagnosis from it. And I'm going to work up one. I've made up 4 for you to look at, and I do have a typo on there. So I have been sitting for quite a while today doing work. Now, CM is a 42-year-old patient admitted as a postoperative GN surgery of a TAH and BSO. That is a total abdominal hysterectomy, bilateral salpingectomy, oophorectomy. Upon assessment, you note she has LR infusing at 125 mils per hour through a left PIV in the antecubital area. There's an epidural infusing in her back at 2 mils per hour with an additional 1 mil. She may receive upon pushing her pump button. So she has the ability to use as a PCA, patient-controlled anesthesia. CM refused to roll to the side so that the epidural site could be assessed. And why do you think it is that she refused to roll to the side? She didn't want to roll because she was hurting. There is a large lower transverse abdominal dressing that is dry and intact. We know under that dressing that she has an abdominal incision. Sequential TED Hoser on. CM has a history of early onset diabetes type 2 since the age of 30. High blood pressure, control of medication, history of depression, and states, I often have panic attacks. CM has been given the pillow her head would lay on while in surgery to practice deep breathing and coughing. CM complains of intense pain at a 7 out of 10. Now, there was probably so much more data that I could actually put into this, but I really wanted this to be just a brief synopsis of this patient and me to just extract as much information that I can and probably make a few things up along the way to get y'all the information you need. So what are our top problems for CM? I identified five possible diagnoses upon my brief patient scenario. 2 are actual problems with 3 risks. There's actually a 4th risk because I forgot that she has depression and anxiety. So we might have some problems with her along the way. Especially as pain levels starts to increase, like she has a 7 out of 10. Does that not cause you a little extra anxiety? Because when you can't get on top of your pain, guess what? You become a little full of anxiety and can probably fly off the handle pretty easily. I'm only going to take the top problem that I identified and expound on it for creating a concept map. For the remaining ones, I'm leaving for you to practice on, including adding essential data to it so that you can see how you can create your problem and go from there. Acute pain, knowledge deficit, risk for ineffective airway clearance, risk for infection, risk for ineffective tissue perfusion. So I put our risk at the bottom there. I probably should have moved our tissue perfusion up above the infection. But it's kind of, I really I wasn't going all out here. I just really wanted to bring y'all to focus on one problem that I could take and go all crazy on. So when I'm building my problem, I have identified acute pain as the first part of my diagnosis. Related to factors are the pathophysiology of the identified nursing diagnosis. Do you know how long it took me to actually understand this? I can't even, I know that I had been teaching. I want to say that the first year that I was teaching and then some, I struggled with that because I just was like, I don't understand. Even from nursing school, I don't remember this. I don't know what is the pathophysiology. And so much paperwork that I probably actually passed that I don't now. Because I couldn't, I would agree with the student and I wasn't following exactly what I needed to lead my students in the right critical thinking, clinical reasoning aspect and area and realm. So the related to factors. If a related to factor sounds like a medical diagnosis, medical treatment, or an assessment, then it is incorrect. And again, I have a typo on there. I did this very quickly. Example, acute pain related to total abdominal hysterectomy. Wrong. This is your procedure. Acute pain related to abdominal incision. Wrong. This is an assessment. You assess the abdominal incision. We know the patient had a TIH and BSO. We know this procedure is done through an abdominal incision, but what caused that pain? How did we perform the surgery? What did we do to get to the uterus? What did we do to get to the tubes and get to the ovaries? And what did we do to get them out? Did we cut the skin through all of the layers? Did we sever the nerve endings? Yes, yes, yes. That's our pathophysiology. Pathophysiology is severed nerve endings in all dermal layers. I was being very specific to our patient here. I didn't go buy a book. I would suggest that you go buy a book. That way that you know that you're given the right pathophysiology. And if you don't know how to read your Carpenito, you really need to learn how, because once I learned how to read Carpenito, honey, my life was forever changed. And if you don't have a Carpenito book, you ought to buy one. So our acute pain is related to severed nerve endings and all the dermal layers secondary to a THBSO as evidenced by CM states pain level at a 7, epidural infusing at 1 mil, 3 mils per hour and 1 mil per hour PRM, patient controlled, abdominal incision, refusing to turn for an assessment of the epidural site from pain, refusing to deep breathe and cough because of pain, guarding incision. Maslow, this is a physiological need. And this is your problem. This is what I would have uh, on that first page of your concept map. This is that right there. My problem. 1 states my pain level is a 7. 2, guarding behavior of the abdominal incision. 3, refusing to deep breathe and cough, stating it hurts too bad. Okay? This is your problem. This is everything in that one problem box. The rest of the concept map, I'm not going through interventions and rationales, but just know these are found in your care plan books, which were a required text to buy. Rationales at this level should not come from your head. From here, we're going to talk SMART goals. Though this was covered very, very much extensively in my nursing process lecture, we're going to look at it again on the next slide. Okay, so when we're planning, we have SMART goals. S is specific. We want to define the goal as much as possible with no unclear language. We want it to be measurable. Can you track the progress and measure the outcome? How much, how many, how will I know when my goal is accomplished? Can it be attainable? Am I giving my patient too much? Am I expecting my laboring patient who is going completely natural in childbirth to have no pain whatsoever? Is that an attainable goal? That absolutely is not an attainable goal. And if that was your goal, then you are far overreaching there. R, is it relevant? Is it relevant to my patient who has decided that she wants to deliver all natural? Nope. Also, we have to look at timely. What do you want for CM? Do you want her to hurt? Do you want her to have some pain relief? Because quite honestly, if you have 5 other patients and she has no pain relief and she's lying down there crying and calling out every 10 to 15 minutes and saying it's not working, then it doesn't work for you either. On the same note, there is not one person sitting and listening to my voice right now on this PowerPoint that wants to have any of their patients in pain. Not one person. So we want a goal for her that doesn't require her hurting. But are we going to be able to take all of her pain away? Because is that an attainable goal? Not necessarily, because what do? We cut through everything. So patient will report a level 3 out of 10 for pain, down from 7 out of 10 with use of epidural pain medication and repositioning within 45 minutes of implemented interventions. I know it sounds like a lot, but it's actually quite simple. It is very specific. Don't you think? It's measurable. We've got the measurements in there. Is it attainable for a patient? Yeah, to take her from a 7 down to a 3 is absolutely attainable. Is it relevant for her? Yep, it is. And is it timely? Yeah, we put a time on there. We want it done in 45 minutes of those implemented interventions. This is the end. This is just a quick, let me see, I have it in here in under 12 minutes. Let me know if you have any questions.